Good morning to you all, and this is my third video, and I have been continuously discussing about UPSC Combined Medical Services typical questions and answers, which generally used to come and is coming also, and just in the exam which took place, the question I have not got, but if it will come in my purview, I will definitely I will discuss. Now, before that, just I want to discuss some of the paper 1 and paper 2 questions of the last 10-15 years which came in the exam. So, just I'm starting with the paper 1 now. Okay, and please, you please take use of the maximum use of this video, and if you have any doubt, you just drop me a message, because I will be posting that in the our Dr. Rajiv's groups, so it will be easier for you. Now, the first question is very easy. The first questions are from the dermatology section, I think, in the paper 1. Rough spots are found in. Now, you think for an answer, then I will give you, and the options are, listen the options carefully. Rough spots are found in acute rheumatic fever or AHF, then CCF, that is congestive cardiac failure, then C is the infective endocarditis, and D is the RCM or restrictive cardiomyopathy. Now you think about that, and for I'm giving you 10 seconds and 10 to 15 seconds, and then I will be discussing the answer with explanation, with mild explanation. Now, I think you have got the your thought for the answer. The correct option will be infective endocarditis, and rough spots are generally seen clinically. If you see, then you will see. Now, before that, you should know that in this question, what are the characteristics of infective endocarditis? You should know. Now, the diagnosis of infective endocarditis, we can suspect if any cardiac patient who has unexplained fever, after ruling out other causes of fever, like it can be anything, it can be mixed, of 7 to 10 days in the presence of embolic phenomenon. So this you should remember. And investigation of when we investigate like CBC and all, ruling out everything like scrub typhus and everything, we see normocytic normochromic anemia, and hemoglobin is around 7 to 10, and the TLC count are usually less than 10,000, like it is a case of leukopenia, and urine examination shows mild albuminuria also, and microscopic hematuria. Now there are criteria, that is Duke's criteria we do. Documentation of 2 major and one major or 3 major or 5 minor criteria allows the diagnosis. That is the 80% accuracy that we follow. If you see the Harrison also, there is the same thing, it is written. And 2 positive blood cultures for microorganism that typically causes infective endocarditis, and persistent blood culture taken more than 12 hours apart, that is the more than 1 hour single positive culture for Coxella brunelli, that is the main culprit for infective endocarditis, and evidence of endocardial involvement determined by echocardiography, and definite vegetation or myocardial abscess or the new partial dehiscence or prosthetic bulb or development for the new regurgitant murmur. And myro criteria are like suppose predisposition or heart condition or fever more than 100.4. This is the main minor criteria. And vascular phenomenon like major arterial emboli, septic pulmonary infarcts, myocardic aneurysm, intracranial hemorrhage, conjunctival hemorrhage, and like immunologic phenomena like glomerulonephritis, which is known as the involving the kidney, etc., and oscillous nodules, that is painful vessels raised finger, toes or feet, and Roth spot. Now remember, don't confuse with the oscillous nodes and the Roth spots. Okay. Now, what are the Roth spots? If I tell you in a single language, if you want to tell what are Roth spots in the infective endocarditis, it is just a exudative lesion in the retina. These are known as the Roth spot. Now, apart from that, rheumatic factor will be increased. Now, the microbiological evidence is positive blood culture, not meeting the criteria of major criteria or serological evidence of active infection with an organism consistent with the infective endocarditis. Now, positive echocardiogram not meeting the major criteria. Now, arthalgia may occur, so there is a and oscillous nodules are a bit uncommon, so we should also take into account. So this is the explanation of the infective endocarditis, and if you see the patient like this, so it will be a case of infective endocarditis. Now, I am coming to the second question. Second question is somewhat like this: 42-year-old smoker has developed an acute MI. The coronary angiogram or the CAG done him is likely to show an obstruction in where the obstruction is likely to show. Now, 42-year-old man, and is a smoker also. Now listen the question carefully and the options also. Now the options are LAD, that is left anterior descending artery, then left posterior descending artery, option B, then right coronary artery, and D, circumflex artery. That is which of the following is the most likely to show the obstruction. Now you think for at least 10 to 15 seconds. Meanwhile, I am seeing which question to ask you. Now this video I will be doing short because I will be quickly discussing the paper 1 and paper 2 also, because last two videos I have only discussed about paper 1 only. Paper 2 I have only 1 or 2 questions. So I will be discussing 3 to 4 questions, the most important, which generally comes in the exam. Repeatedly it comes in the exam. Now I think you have thought for the answer. The answer will be question I am repeating again. A 42-year-old smoker has developed an acute anterior myocardial infarction, and the CAG or the coronary angiogram done on him is likely to show an obstruction on where? That is LAD, left anterior descending artery, or left posterior descending artery, or right coronary artery, or circumflex artery. So the answer of that will be, it's an easy question, it will be a left anterior descending artery. Now explanation for that would be that left coronary artery supplies mainly where? It's anterior and left portion of the left ventricle, where the right coronary artery supplies the right ventricle of the. Now MI develops as a result of the hamper of blood supply to the concerned artery. Now you should understand the branch of right coronary artery and supply. Now right coronary artery supplies what? Now right coronary artery anterior surface of the pulmonary conus, arterial branches of SA node, and it is 60% of the case, anterior ventricular branch, that is anterior surface of the right ventricle. So right coronary artery supplies this sort of vessels and nerve. And posterior involvement of the artery, posterior part of the intraventricular septum also, or IVS, and AV node, and right and left ventricle. Now in the case of the left coronary artery, you can see that it supplies the left anterior descending or anterior intraventricular artery, and then the anterior part of the intraventricular septum, greater part of the great vesicles and the part of the right ventricle and part of the left ventricle of his. So, and circumflex artery, left margin of the left ventricle up to apex, conus artery and pulmonary counts and arterial branch, that is the left atrium. So, in this case, when the person has been diagnosed as a acute anterior wall MI, so firstly we have to rule out by seeing the ECG. The ECG will be a typical one. So acute anterior wall myocardial infarction will likely to show an obstruction in the LAD, okay, left anterior descending artery. Now, I'm coming quickly to the paper. Now 2 questions I have discussed, and now I am coming to the paper 2. Now, this is also a very important question now in obs and gynecology. That is, which of the following hematological parameters, now listen the question carefully, very important and straight line question. Which of the following hematological parameters does not undergo a physiological increase during normal pregnancy? Now, when a normal pregnancy occurs, which of the following, generally all the things increases, which of the following does not increase? But which of the following is not a physiological increase? Like blood volume, red cell volume, leukocyte count and platelet count. Now you think for at least 5 to 6 seconds, take 5 to 6 seconds and then I will be coming with the answer. Sorry. Now, this is a very tricky question which I have asked. Now, the answer, which is a very tricky one. Now, which of the following hematological parameter does not undergo physiological increase? Now, see, blood volume generally increases. Okay. Now, red cell volume also increases. When the blood volume will increase, red cell volume will be increased, and leukocyte count also increases. Now, that is a physiological one. That is not due to infection. If any undergoes secondary infection comes, then we have to treat that. Now, here the only option left is the platelet count. Now, see, the platelet count generally we see that it does not increase. There is a there is not a case of thrombocytosis or increase in the platelet count, but some rare cases we have also gone through to increase the platelet count. But here, since the question is direct, when this type of question has been asked repeatedly or 2, 3 years, 4 years, 5 years, so if this question comes like that, so you have to answer the platelet count, because here platelet count is only the diagnosis of exclusion, where the physiological increase during pregnancy does not occur. So now I am coming to the another question. Now a 15-year-old unmarried girl which complains of the dysmenorrhea for the last 1 year. Okay, now listen the question carefully, very good question. Now, a 15-year-old unmarried girl presents with a complaint of dysmenorrhea for the last 1 year, and she achieved menarche 12 years ago, and the 12 years of age. On abdominal rectal examination, she has no abnormality. Now, which is the most appropriate management? Now, here the question is that 15-year-old unmarried girl and complaints of dysmenorrhea for last 1 year, and menarche she has achieved in 12 years of age, and abdominal examination there is nothing, no abnormality. So what we should do? Now option, you listen the option and take 5 to 10 seconds and then you will answer. Option A is prescribe antibiotics, then B prescribe clotrimazole vaginal ovules or clotrimazole vaginal suppository, which is more specific for you. C is reassure her and prescribe analgesic, and D perforation DNC, that is dilatation and curettage. So here I think you take you at least 5 seconds, 5 to 10 seconds, then I will be coming with the answer. Now I think you have come with the answer. Now here the again I'm repeating the question again. A 15-year-old marriage unmarried girl, okay, unmarried girl present with a complaint of dysmenorrhea for the last 1 year, and she achieved a menarche 12 years ago, and on abdominal rectal examination there is no abnormality found. So here there are 4 options: prescribe antibiotics and giving clotrimazole suppository and perform DNC. No need of all the 3 options. You have to only reassure, because see this the case of primary dysmenorrhea as far as the question is concerned, and excessive myometrial contraction ischemia and excessive prostaglandin production do occurs, and the factor which increases the risk is younger age, the BMI less than 20, and I think the question is not given about the BMI, but it is thought to be, and prolonged duration of menses, and the duration of menses is already mentioned: heavy menses, hospitalization, family history. There is the increasing risk, and factor decreasing the risk of physical exercise used in the OCP, younger age of first childbirth, higher parity, and the main thing is which has occurred to this girl within 2 hours of menarche, that is 18 to 20 hours, and she has achieved the menarche in 12 years. So she is on the high risk of developing dysmenorrhea, and the description is she will develop cramping and all the back, inner thigh, and here the pelvic finding and all the findings which is in the question only, it will be a completely a normal one. Now the management, how to manage this patient. Now no need reassurance, and if the patient comes to you, always you have to give the NSAIDs, antispasmodic, OC pills. Rarely surgery is required, because surgery generally we don't prefer to do. Transcutaneous electrical nerve stimulation or Cottle's operation for the laparoscopic uterosacral nerve ablation, that is LUNA, and laparoscopic presacral neurotomy via T11 and T12 cervical canal dilatation, that is all we do. But generally we not prefer to do, we generally reassure and we give psychological treatment and NSAIDs, and that is all. The patient is being counseled, and the patient is completely cured. So here is the primary dysmenorrhea. Now this question I am discussing of paper 2. Again I am going to the paper 1. Sorry. Now here a very important question on the from the paper 1 is given: the broadcast which is seen in the urinary sediment. Broadcast seen in the urinary sediment is specific for what? Now you listen the question carefully, and then you answer. It is for option A, ARF, that is acute renal failure. B is the rapid progressive renal failure, or that is acute to chronic, which is rapidly progressive. And C is CRF, that is chronic renal failure. And D is asymptomatic urinary abnormality. Now, here the option is very fun. The cast which is seen in the urine of broadcast are generally, when you see in the microscope, it is generally indicative of the chronic renal failure. It is a very straightforward question. And cast generally we also see in non-cliniopathical in pathological condition also, like in the fever and all. So there are different types of cast which I will discuss when I will discuss in the laboratory medicine in another video, if I get a time to do. But broadcast, like red cell cast and Vaxi cast and hyaline cast, all these cast. So broadcast are typically, it is indicative of CRF. So just to remember this, and this is only the question, because see, you can see in the paper 1 and paper 2 in UPSC particularly, they are asking the question in very simple, in very directive way. They are not asking the question in any indirect way, like in NEET or NEET PG. You have seen the question in anatomy or in the physiology or in any paper of the 18 papers or 19 papers. They are asking the question in the twisted way. But in the case of UPSC, the question is very straightforward, and the chance of you getting 100 upon 100 is very, very high. So this is the thing. And now again I am discussing one more question, very important question it is, and it is also this question which I am going to discuss you right now. It is also been asked several times in one way or the other. The characteristic abnormality found in the urinalysis in the case of acute glomerulonephritis. Now listen the option and listen, I am repeating you the question once again. The characteristic abnormality found in the urinalysis of the acute glomerulonephritis is what? It is granular cast, red cell cast, hyaline cast, WBC cast. Now you have to select the answer using the code below. Option 1 ABC, remember it. Option 1 ABC, option 2 A and D, option C only C, and option B B only. Okay. So I am repeating the question again and again for you. The characteristic abnormality which is found in the urinalysis of acute glomerulonephritis patient like is granular cast, red cell cast, hyaline cast, WBC cast. Now you have to select using the code, like option 1 is ABC, option 2 A and D, option 3 C, and option 4 B. So you think for 10 seconds and I will be giving you the answer with explanation mild. So I think you have come up with the answer, and the granular the characteristic abnormality found in the analysis of the case in the case of the acute glomerulonephritis, that is AGN, granular cast, red cell cast, hyaline cast, WBC cast. So here, as per the case of the acute glomerulonephritis, only we find in microscope only and only RBC, that is red cell cast. Now some of the mild explanation is acute glomerulonephritis is also known as nephritic syndrome. It is not known as nephrotic. Nephrotic means nephrotic range proteinuria, or more than 3 grams of proteins in the urine, and that is known as the acute nephritis. This is the case of actually acute glomerulonephritis, acute nephritic syndrome. So it comprises of hematuria, microscopic. Okay, it can be macroscopic also, but microscopic is the more common. And red cell cast typically present in the urine microscopy, as I told you earlier, and with proteinuria, hypertension, edema, and temporally oliguria or uremia. And the histological pattern, if you go in the pathology part, the histological part can also be, it is characterized by cellular proliferation, meningeal or endothelial, and inflammatory cell infiltration, which is neutrophilic macrophage. And although granular and WBC cast may be found, but it is not characteristic. Now, as I told you that granular or WBC cast may also be found, but it can be like twisted and it can be given in the exam like that, WBC caste or granular caste. So you have to answer here RBC caste, because RBC caste are the characteristic feature of the nephrotic syndrome, and here it is a acute nephrotic syndrome. Now, I am asking the question, the last question which I am discussing to you is the paper 1 only. It is a question of ENT perhaps. Now see, the question has been here, the question is again easy, and the young boy with a history of left ear discharge. Now, Now, a young boy with a history of left ear discharge develops fever, headache, vomiting, local seizure of upper right limbs, and the appropriate line of management. Okay. Now, the patient presents with the this is a young boy with a history of left ear discharge. He develops now the triad you can see, and the fever is there, headache is there, vomiting is there, and the focal seizure of the right upper limb. Okay, so the appropriate line of management is what? What is the appropriate line of management? And the option you see first, and option you see first, and then you decide. Urgent CT, head, and antibiotics. Option A, urgent CT and antibiotics. B is urgent EEG and antibiotics. C is urgent otoscopy and antibiotics, and urgent CBC, complete blood count, and antibiotics. Okay. Now here actually you think for the answer, then I'm giving you the answer. Now option I am giving you again: urgent CT with antibiotics, urgent EEG, okay, electroencephalogram with and antibiotics, urgent otoscopy, and urgent CBC with antibiotics. Now I think you have come up with the answer. Here the answer will be option A, that is urgent CT with the antibiotics. Why? Why urgent CT with antibiotics? Now you see that the patient is suffering, he is giving the history of left ear discharge, so, and fever, headache, vomiting, focal seizure, etc. So the patient is probably suffering from the complication of the SOM, suppurative otitis media, and probably brain abscess, temporal lobe abscess, and 50% of the pregnancy adult and 25% children are otogenic origin, and in adult abscess I usually follow, and when it is a CSOM, it is definitely a CSOM, because when the seizure has been setting in, it is CSOM. And while cholesteatoma, while in children, it is done with the acute otitis media. Now the clinical features is cerebral infection, initially of rare temperature, chilled and rigor, okay, headache, vomiting, convulsion, and fit. So it is meeting the criteria. And increased ICT is there: headache, nausea, vomiting, loss of consciousness, papilloedema, focal sign, that is dysphagia, aphasia, upper quadrant hemangiopia, okay, unsunate fit, etc. Now here the investigation of choice will be CT only. It is a non-contrast CT will be done, and you can see best to you can easily locate the site where the abscess is, and the treatment will be antibiotic and evacuation of the abscess through aspiration, excision of the burr hole or the open incision. Now, so this is the first very important question, and it is the case of acutely chronic suppurative otitis media, and we have to do urgent CT with antibiotics, and we have to give antibiotics. Patient completely recovers well if treated promptly. So these are the some of the questions. Now you can see when I have discussed some of the questions, 6-7 questions I have discussed. I have not discussed more than question because the time is over. So I have seen that most of the question which you can also see and judge is very direct question. They are asking, not they are indirect questions. So again I will come with the some more question, and here in my part 4 video I will be discussing only and only of question of paper 2. Now I will be spending around 15 to 30 minutes, around 30 minutes, half an hour video of discussing only with question 2, paper 2, and then again I will be coming on paper 1. And in the meantime, if I get the opportunity, if I get through access through the exam which took place on this year, UPSC 25, I will try to make the answer, and I will be explaining you with the definite answer. So till then, be good and prepare well for your next UPSC 26 upcoming examination. And if again I am telling, if again you have any doubt, you can come up with my in my personal WhatsApp number, which is always in the group, Dr. Rajiv Sir's group, and you can ask me there also. Thanks a lot.